Hello students, now we will see communication disorders, under which we have expressive language disorder, mixed expressive receptive language disorder, phonological disorder and stuttering. We will see all of these disorders in detail right from their introduction, definition, causes, symptoms, diagnosis to treatment and prevention. First, a communication disorder is a speech and language disorder which refers to problems in communication and in related areas such as oral motor function. The delays and disorder can range from simple sound substitution to the inability to understand or use one's native language. And the causes may be developmental or acquired. It is believed to be based on biological problems such as abnormalities of brain development, possibly by exposure to toxins during pregnancy, such as abused substances or environmental toxins such as lead. There could also be a genetic factor involved sometimes, which could be a contributing cause in some cases. And some causes of speech and language disorders include hearing loss, neurological disorders, brain injury, mental retardation, drug abuse, physical impairments such as cleft lip or palate, and vocal abuse or misuse. However, frequently the cause is unknown. Expressive language disorder, the essential feature of it is an impairment in expressive language development in a child as demonstrated by scores on standardized individually administered measures of expressive language development, and it is found to be substantially below those obtained from standardized measures of both nonverbal intellectual capacity and receptive language development. And the difficulties may occur in communication involving both verbal language and sign language. The linguistic features of the disorder vary depending on its severity and the age of the child. These features could include a limited range of speech, limited range of vocabulary, difficulty acquiring new words, word finding or vocabulary errors, shortened sentences, simplified grammatical structures, limited varieties of grammatical structures, limited varieties of sentence types, omissions of critical parts of sentences, use of unusual word order, and slow rate of language development. And non-linguistic function as measured by performance intelligence tests and language comprehension skills are usually found to be within normal limits. Expressive language disorder may be either acquired or developmental. In the acquired type, an impairment in expressive language occurs after a period of normal development as a result of neurological or other general mental condition such as head trauma, irradiation. In the developmental type, there is an impairment in expressive language that is not associated with neurological origin, and children with this type often begin speaking late and progress more slowly than usual through the various stages of expressive language development. And the prevalence estimates vary with age. In children under 3, language delays are quite common, occurring in about 10 to 15% of children. And by school age, the prevalence estimates range from 3 to 7%. The developmental type of expressive language disorder is more common than the acquired type. And the DSM-4 lists the following criteria. First, the scores obtained from the standardized individually administered measures of expressive language development are substantially below those obtained from standardized measures of both nonverbal intellectual capacity and receptive language development. And the disturbance may be manifest clinically by symptoms that include having a markedly limited vocabulary, making errors in tense, or having difficulty recalling words, or producing sentences with developmentally appropriate, inappropriate length or complexity. And second, the difficulties with expressive language should interfere with academic occupational achievement and with social communication. And third, the criteria should not meet for the mixed receptive expressive language disorder or a pervasive language disorder. And if mental retardation or a speech motor or sensory deficit or environmental deprivation is present, the language difficulties should be in excess of those usually associated with these problems. The prognosis, coming to the prognosis part of expressive language disorder, It's usually recognized by age 3, but milder forms of the disorder may not become apparent until early adolescent, when language ordinarily becomes more complex. The acquired type of it could be due to brain lesions, head trauma or stroke, and it might occur at any age, and the onset is sudden. The outcome of the developmental type of expressive language disorder is variable. The majority of children with this disorder improve substantially, but in a smaller proportion, difficulties persist into adulthood. Most children ultimately acquire more or less normal language abilities by late adolescent, although subtle deficits may still persist. And in the acquired type of expressive language disorder, the course and prognosis are related to the severity and location of brain pathology, as well as to the age of the child and the extent of language development at the time the disorder is acquired. Clinical improvement in language abilities is sometimes rapid and complete, although deficits in communication and related cognitive abilities may still persist. In other instances, there may be progressive deficit. Let us now see mixed receptive expressive language disorder. It's diagnosed when a child has problems expressing him or herself using spoken language and also has problems understanding what people say to him or her. And mixed receptive expressive language disorder is generally a disorder of childhood, and in this as well there are two types. It could either be developmental or acquired, and developmental mixed receptive expressive language disorder does not have a known cause and normally appears at the age that a child is learning to talk. An acquired mixed receptive expressive language disorder is caused by direct damage to the brain, and it could occur suddenly after such events as a stroke or traumatic head injury. Researchers are conducting ongoing studies to determine whether biological or environmental factors are involved in this disorder, but they haven't yet found anything. And coming to see the prevalence of this disorder in the general population, it's found among 5% of preschool age children and 3% of children in school. It is less common than expressive language disorder, but children who have mixed receptive expressive language disorder are more likely to have other disorders. Between 40 and 60% of preschoolers who have this disorder may also have phonological disorder, that is difficulty in forming sounds. And reading disorder is also linked to as many as half the children with mixed receptive expressive language disorder. Children with this disorder are more likely to have psychiatric disorders such as ADD, attention deficit disorder. It's estimated that 30 to 60% of children with this disorder also have ADD, and children from families with a history of language disorders are more likely to have this or other language disorders. The signs and symptoms of mixed receptive expressive language disorder are for the most part the same as the symptoms of expressive language disorder. And in general, mixed receptive expressive language disorder is characterized by a child's difficulty with spoken communication. The child does not have problem with the pronunciation of words, which is found in phonological disorder. Rather, the child has problem constructing coherent sentences using proper grammar, recalling words, or similar communication problems. A child is not able to communicate thoughts, wants, or needs clearly at the same level or with the same complexity as his or her peers. In addition, the child often has a smaller vocabulary than his or her peers. And children with this disorder also have significant problem understanding what other people say, as I said, and this lack of comprehension may result in inappropriate responses or failure to follow directions. This could lead people to think that they are being obnoxious or stubborn, whereas that is not the case. They simply do not understand what is being said. And some children with this disorder have problems understanding such specific terms as abstract nouns, complex sentences, or spatial terms. And the disorder is usually diagnosed in children because a parent or teacher expresses concern about the child's problem with spoken communication, and the child's pediatrician may give the child a physical examination to rule out such medical conditions as hearing loss. Specific testing for mixed expressive receptive language disorder requires the examiner to demonstrate that the child not only communicates less well than expected, but also understands speech less well. It can be hard to determine what a child understands. As a result, most examiners will have non-verbal tests in addition to tests that require spoken questions and answers in order to assess the child's condition as accurately as possible. And in children who are mildly hearing impaired, the problem can often be corrected by using hearing aids, and children who speak a language other than English at home should be tested in that language. And the DSM-4 lists following criteria to diagnose a child as mixed receptive expressive language disorder as having the disorder. The first criterion stages that the child communicates using speech and appear to understand spoken language at a level that is lower than expected given the child's intellectual abilities and the age appropriate education. Second, the child's problem with self-expression and comprehension must create difficulties for him or her in everyday life or in achieving his or her academic goals. And if the child understands what is being said at a level that is normal for his or her age, then the diagnosis would be given as expressive language disorder. If the child is mentally retarded, hard of hearing, or has other physical problems, the difficulties with speech than what generally occurs with other handicaps the child may have in order for the child to be diagnosed with this disorder. Now, coming to prognosis, the developmental form of mixed receptive expressive language disorder is less likely to resolve well than the developmental form. Most children with the disorder continue to have problems with the language skills. They develop them at a much slower rate than their peers, which puts them at a growing disadvantage throughout their educational career. Some persons diagnosed with this problem have significant problems in expressing themselves and understanding others in adult life as well. The prognosis of the acquired type of mixed expressive receptive language disorder depends on the nature and location of the brain injury. Some people get their language skills back over days or months. For others, it takes years, and some people never fully recover expressive language function or the ability to understand speech. Let us see in this module the phonological language disorder. Speech disorders may be problems with the way sounds are formed, called articulation or phonological disorder, and there may be difficulties with the pitch, volume, or quality of the voice. There may be a combination of several problems. People with speech disorders have trouble using some speech sounds, which can be a symptom of a delay. All communication disorders adversely affect a child's educational performance. And phonological disorder includes phonological production, that's the articulation, errors that involve the failure to form speech sounds correctly, and cognitively based forms of phonological problems that involve a deficit in linguistic categorization of speech sounds. Example, a difficulty in sorting out which sounds in the language make a difference in meaning. Severity ranges from little or no effect on speech intelligibility to complete unintelligible speech. Sound omissions are typically viewed as more severe than or sound substitutions, which in turn are more serious than sound distortions. The most frequently misarticulated sounds are those acquired later in the developmental sequence, but in younger or more severely affected individuals, consonants and vowels that develop earlier may also be affected. And phonological disorder may involve errors of selection, ordering of sounds within syllables and words. Example, AKS for ASK. And approximately 2% of 6 to 7 years have been found to be affected with phonological disorder. It might present with moderate to severe phonological disorder. Although the prevalence of milder forms of disorder is higher, the prevalence falls to 0.5 by age 17 years. In severe phonological disorder, the child's speech may be relatively unintelligible even to family members, and less severe forms of the disorder may not be recognized until the child enters a preschool or school environment and has difficulty being understood by those outside the immediate family. The course of the disorder is variable depending on associated causes and severity. In children with mild to moderate phonological problems, which are not due to general medical condition, about 3/4 show spontaneous normalization by age 6. The diagnostic criteria for phonological disorders are failure to use developmentally expected speech sounds that are appropriate for age and dialect, example errors in sound production, use, representation, organization, but not limited to substitution of one sound for another, example T for K. And second, the difficulties in speech sound production should interfere with academic and occupational or social communication. Third, if mental retardation, a speech motor or a sensory deficit or environmental deprivation is present, the speech difficulties should be in excess of those associated with these problems. If a child meets the criteria I have just given, then he or she would be diagnosed for phonological disorder. Now let us come to stuttering. Stuttering involves problem in speech. For example, the child may have problem in sound and syllable repetitions, sound prolongations, interjections. He might even have problems like breaking words, pausing within a word, audible or silent blocking, filled or unfilled pauses in speech, and words produced with an excess of physical tension, monosyllabic whole word repetitions. So, if a child has one or more of any of the problems I have just given, then he would be diagnosed for stuttering. And in addition to that, these disturbances in fluency should interfere with academic or occupational achievement and with social communication. And if a speech motor or sensory deficit is present, the speech difficulties should be in excess of those usually associated with that problem. Now let us see the assessment of the language disorder. Most children with communication disorders are first referred for speech and language evaluations when their delays in communication are noted. A child psychiatrist is usually consulted, especially when emotional or behavioral problems are also present, and a comprehensive evaluation involving psychometric tests designed to assess logical reasoning abilities and reactions to different situations and thinking performance are all assessed, and their psychological tests of cognitive abilities would also be assessed. And after assessing and diagnosing a child with the specific communication disorder, the next step is to find an appropriate treatment or an intervention for the child. And specific treatment for communication disorder will be determined by the child's physician, special education teachers, and speech language and mental health professionals based on the child's age, overall health and medical history, the extent and the type of the disorder, and the expectations for the course of the disorder, as well as the child's tolerance for specific medications or therapies. So, a coordinated effort between parents, speech or language and mental health professional has to be taken. They could provide the basis for individualized treatment that could include individual or group remediation, special classes or special resources. Special education techniques could also be used to increase communication skills in the areas of the deficit. And a second approach could help the child build his or her strengths to overcome his or her communication deficit. And speech language pathologists could assist the child who have communication disorders in various ways. They could provide the individual therapy for the child, consult with the child's teacher about the most effective way to facilitate the child's communication in the class setting, and work closely with the family to develop goals and techniques for effective therapy in class and as well as at home. And in all the communication disorders, as in any other disorder, early detection and intervention can address the developmental needs as well as the academic difficulties to improve the quality of life experienced by the children with communication disorders. The speech language pathologist may assist vocational teachers and counselors in establishing communication goals related to the work experiences of student and suggest strategies that are effective for the important transition from school to employment and adult life. A recent research review has found that treatment of communication disorders in young children come to two clear conclusions. Early intervention for all types of communication disorder can be effective and more efficient than that provided at later stages. And second fact is that sound clinical judgment is needed to determine the treatment goals, strategies, settings and procedures that are best for any given child's needs. And depending on the type and the severity or the age of the child, three basic styles of intervention could be adapted, which could facilitate communication, language and speech development. And these styles include therapist directed approaches, child centered approaches, or a combination of these two approaches. Therapist directed approaches is what most people think about when they imagine what speech directed speech therapy might look like. These approaches include traditional drill play. This is when the child practices the speech sounds for a certain number of times and then gets to take a turn at a game or other preferred activity. These approaches also include modeling correct speech production by the speech language pathologist, and the approach is generally structured with clear targets and corrective guidance offered by the speech language pathologist. In the child centered approach, it could also be called indirect language stimulation or facilitative play or naturalistic. In this approach, focus is given on the child. This approach focuses on teaching communication skills the way most typically developing children naturally develop their skills, by playing and interacting with others. So, we have seen all of the communication disorders in detail. We have understood its epidemiology, its prevalence in the general population, whether they are of a developmental type or an acquired type. We have seen its assessment and diagnosis part as well as intervention. So, hope these details would be enough to understand communication disorder.